Hi, everybody. Good evening. Thank you for joining us for today's session on cardiac care and Friedreich's ataxia. My name is Kayla White, and I'm a community education specialist at MDA. We're thrilled to have you join us today for this webinar. This learning series is part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to the website for on-demand viewing at a later date. Please know that all phone lines have been muted, but we will have a question and answer session at the end of the webinar. You can use the chat feature to type in your questions and feel free to send those in as you think of them. They'll all be addressed after the presentation. I would also like to thank our webinar supporter, Reata Pharmaceuticals. We would not be able to provide community education webinars like this if not for their generous support, and we are very thankful and appreciative. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer, more independent lives. Our mission comes to life through these four pillars. First, care. Second, champion. Third, catalyst. And fourth, community. If you haven't done so already, we invite you to join the MDA community by registering with us. I would now like to introduce today's guest, Dr. Kimberly Lin. Dr. Lin is an attending cardiologist in the Cardiac Center and the medical director of cardiomyopathy at Children's Hospital of Philadelphia and has expertise in heart and lung transplantation. Dr. Lin is kind enough to join us after a very long day of surgery, so we're so excited to have you here, and I will now turn the time over to you.
So much, Kayla. And thanks to all of you who have made time to join tonight. I hope that the things that I share with you tonight are useful, and I do understand that there'll be some time for questions as well. So again, as Kayla mentioned, I'm a pediatric cardiologist. I was asked to speak tonight at first just about clinical care in general, but also specifically about cardiac care in Friedreich ataxia. So I'm going to attempt to do both. I'll give you first my area of expertise and then also point you towards some resources that we can all lean into on a wider scale with respect to clinical care for people who live with Friedreich ataxia. So for those of you who've been to any of the symposia that we give through the Friedreich Ataxia Research Alliance, I apologize if this is repetitive for you, but I did want to start at a basic level to make sure we're all on the same basic understanding. So in terms of what we know about Friedreich ataxia, which I've abbreviated here as FRDA, and the involvement of the heart, we know that the heart is involved eventually in most people, not all people, but most people with Friedreich ataxia. The most common way that heart manifestations show up is a hypertrophic cardiomyopathy, sometimes abbreviated HCM. And the pattern of this hypertrophy or extra thickness of the heart can be either concentric, meaning all the way around, or asymmetric, meaning more thick on one side than the other, thick on the bottom chamber or chambers of the heart. A little bit more detail about that. Some people in cardiology are very specific about only referring to a heart condition as hypertrophic cardiomyopathy if it is related to a gene change in the heart muscle, the sarcomere. But others of us refer to more broadly to the condition of hypertrophic cardiomyopathy as encompassing conditions that can cause thickening of the heart, including gene abnormalities that cause Friedreich ataxia. So when you hear people talk about, say, typical or sarcomere gene mutation hypertrophic cardiomyopathy, that's in contrast to a wider understanding of hypertrophic cardiomyopathy that would include folks, for example, who have thickening related to Friedreich ataxia. Now, in both types, the more specific HCM that's sarcomere gene related, or in hypertrophic cardiomyopathy related to conditions like Friedreich's, this can progress over time to a dilated cardiomyopathy, wherein it's not just that the heart walls are thick, those walls may actually thin out, but the chambers of the heart may get bigger. Also important to know, arrhythmias or abnormal heart rhythms have been observed in folks with FA, especially abnormal heart rhythms that start in the top chamber or the atria of the heart. That is, again, in contrast to more typical sarcomere gene mutation HCM, where there's a higher degree of concern about arrhythmias that start from the bottom chambers or the ventricles. So this is just a generalized diagram of what the heart may look like in anyone, not just Friedreich's, if they have either normal thickness, shown here on the left, versus hypertrophic or extra thick muscle. So you can see in contrast the septum, that wall between the two bottom chambers, is often thick, and sometimes the free wall of that ventricle there is also thick. And finally, I mentioned that sometimes the hearts can thin out and become dilated. You can see here that the chamber size of the heart here is bigger than normal, and in those who have hypertrophied ventricles. And so this is what we refer to as a dilated cardiomyopathy, especially when the heart muscle is not squeezing as well. Why do folks with Friedreich ataxia often develop cardiomyopathy? We're actually not sure the precise cause of cardiomyopathy in Friedreich ataxia. There are several mechanisms that have proposed, and the honest truth probably lies in a combination of these factors. At a cellular level, iron accumulates in places where it ought not accumulate, and there's a lack of iron-sulfur clusters that can properly function, therefore causing the energy-producing parts of our cells, the mitochondria, to have dysfunction. And there also may be oxidative stress related to these dysfunctions that causes heart muscle problems. So how does this show up, or how do people with cardiomyopathy or arrhythmias in FA feel? Well, heart signs and symptoms usually occur late in the course of disease. They may sometimes show up before neurologic symptoms, but the more typical person with Friedreich ataxia does not experience heart symptoms until after they've experienced neurologic symptoms. Those heart symptoms can include difficulty breathing, especially with exertion, when trying to do more active things. And it also can include chest pain, which we'll talk a little bit more about later. There are some studies that suggest that the frequency of heart muscle involvement increases with the size of the GAA repeat that causes Friedreich ataxia on a genetic basis. So folks may know already that the underlying genetic cause of Friedreich ataxia is expansion of these GAA repeats on the shorter copy of the frataxin gene. Folks who have longer GAA repeats tend to have more symptoms in terms of neurologic effects. And then there are some studies that suggest that the heart problems may be more frequent or more severe in those also who have those longer GAA repeats. However, the degree of neurologic symptoms and the degree of heart involvement do not necessarily correlate with one another. So it's not necessarily true that someone who has very mild FA symptoms from a balance perspective, for example, it's not necessarily true that they won't have significant cardiomyopathy, and vice versa. Someone who has lesser cardiac involvement may have a lot more neurologic involvement. So they're not always tied together. So to this question of chest pain. Chest pain is a common symptom in all forms of hypertrophic cardiomyopathy, and we think that that's due to an imbalance between how much the heart muscle wants oxygen and how much it gets, perhaps not because the big arteries that provide oxygen to the heart muscle are occluded, but perhaps because some of the smaller blood vessels are unable to get oxygenated blood to all of the heart muscle, potentially because the heart muscle itself is so thick, or heart relaxation or diastole is affected and perhaps not as efficient. Macrovascular disease, meaning coronary artery disease where you can see blockages, is not commonly seen in Friedreich ataxia, although of course, if you're someone who has Friedreich's but also has a risk factor such as a family history of early heart disease, high cholesterol, a history of diabetes, which can be more common in Friedreich ataxia than in those who don't have it, those risk factors still may apply and add to your risk of having coronary artery disease. But Friedreich itself doesn't import a higher risk of having large coronary blockages. So one point I think is really important to recognize in Friedreich ataxia that chest pain does not necessarily mean that a person is having a heart attack. Now, the way that a typical person is diagnosed with a heart attack includes symptoms like chest pain, and then also evidence of the heart muscle not getting the oxygen that it needs. And usually that's reflected in things like changes on an EKG or certain enzymes that can show up in the bloodstream, so a blood test. However, we've found out that folks who have Friedreich ataxia may have elevated blood markers, meaning troponin levels in their bloodstream, even if they're well, having no symptoms, and clearly not having a heart attack. And similarly, we found that a lot of folks with Friedreich ataxia do not have normal EKG tracings compared to a healthy population, even if they're not having a heart attack, even if they're not having symptoms. And so if someone shows up in an emergency room and the ER physician doesn't know that their EKG is abnormal at baseline, or doesn't know that folks with FA can have troponin in their bloodstream even when they're well, they may misinterpret those values as indicating a heart attack in someone who's presenting with chest pain. So these are important things to know, and potentially knowing what your baseline is important to be able to convey to a physician at a time of, an ER presentation. Well, unfortunately, we do know that heart disease does provide a risk factor for problems in those who have Friedreich ataxia, not surprisingly perhaps, but in this review by Dr. Lynch and his group many years ago, we did see that of those in a large group of folks with Friedreich ataxia who were known to have passed away earlier than expected, heart causes were one of the most common causes identified. And that's a really sobering fact, given that we don't have currently any Friedreich ataxia specific treatments for the heart disease that occurs. So this is something that we've taken very seriously, and we're making a lot of effort to understand better what happens to the heart over time in folks with Friedreich ataxia, what treatments may be helpful, and how can we prevent heart disease from either occurring or from causing problems early on in Friedreich ataxia patients. One question I often get from folks who are new to the FA community is how often should someone with Friedreich ataxia see a cardiologist? We believe that cardiac screening should begin soon after Friedreich ataxia is diagnosed, so we can get a handle on how does the heart look right now. And then regular follow-up should increase during periods of accelerated growth, for example, in adolescence, if a child is diagnosed with Friedreich's, and or if there's a new concern, for example, new symptoms or abnormal heart rhythms. When someone goes to see a cardiologist, the things that you may expect, other than, a detailed history, family history, and assessment for any symptoms that may be related to the heart, a cardiologist is going to want to look at your heart. Most often, that's with an ultrasound of the heart or an echocardiogram. Alternatively, although it's not available as quickly or as commonly, a cardiac MRI is another way to look at the heart that can be very useful, but that generally takes a little bit of advanced arrangements because it's a longer test and there aren't as many cardiac MRI machines available as there are echocardiogram machines in the office. The second thing that a cardiologist will want to do is evaluate the heart rhythm of their patient. So an EKG or ECG, it depends on if you're going by the German or the American abbreviation, is a 6-second snapshot of the heart rhythm and also gives us a sense of, how the electrical signals are transmitted through the heart. So that's one test that one will very commonly get during a visit with a cardiologist. There are also longer rhythm monitor options. For example, a Holter monitor that can be worn for anywhere from 24 hours to sometimes 7 to 14 days. Those used to all have wires attached to them in order to transmit data and record data. There are now patch monitors available that can be worn without wires attached. All the mechanisms for recording are contained within the patch. Some of the common names for those are Zeo patches or BioTel patches, and those can typically again be worn anywhere from 24 hours to 14 days. And then for those who need their rhythms monitored for even longer, for example, folks who are having very intermittent symptoms and it's important to try to catch what the rhythm is doing at that point in time, but it may not happen for weeks on end, an implantable loop recorder may be helpful to be able to monitor the heart rhythm. Also potentially asked for at a cardiologist visit would be a functional assessment. And in here, an exercise stress test or a CPET test, cardiopulmonary exercise test, may be requested. However, it depends on what kind of equipment is available in the office, and then also, whether the information obtained from an exercise stress test is going to help understand and manage somebody. And then finally, related to that slide I had just a few minutes ago about knowing your baseline, laboratory studies, including a baseline troponin level and a baseline BNP level, may be helpful, not necessarily in that moment if someone's feeling well and not having any symptoms of concern, but to be able to compare with if there are symptoms that occur in the future. And then here's just an example of an echocardiogram. So these are still pictures, but usually you can see them moving. This is an image of a normal heart with normal thickness. And then here we have an example of a heart that is thicker, both here in the septum and in the free wall. You can see the cavity of the heart is less than the cavity of the normal heart because the heart muscle is taking up so much of that space. Then here's an example of a heart that's somewhat thick, but also has progressed to not squeezing quite as well. And then here's more of a dilated cardiomyopathy heart, where the heart is no longer thick, and also the chamber size is bigger, and the squeeze of the heart is clearly less than it had been over here for a normal heart. What medication should someone be on if they have a thick heart? Well, currently, there are no medications that are of proven benefit if someone has no symptoms and has no outflow tract obstruction. So sometimes the heart muscle gets so thick that it gets in its own way, and there's obstruction of blood flow as it tries to leave the heart. That is uncommon in Friedreich ataxia. But for those who do have outflow tract obstruction, there are some standard medicines that can be considered, including beta blockers, such as metoprolol, calcium channel blockers, such as verapamil, and another older medicine that helps with rhythm and with outflow tract obstruction called disopyramide. For people who have symptoms, such as chest pain that's not thought to be due to another cause, such as asthma or reflux, beta blockers and calcium channel blockers again can be considered. And the thought behind those is that if you decrease the heart rate and you decrease the heart's demand for oxygen, you may improve the balance between the supply and demand and decrease symptoms then. Finally, for folks who have abnormal heart rhythms going along with a thickened heart, one can consider medicines that can prevent the abnormal heart rhythms, so antiarrhythmics. And then also, if there are abnormal rhythms coming from the bottom chamber, one can consider an internal cardioverter defibrillator if that's appropriate. What if someone has progressed to having a dilated cardiomyopathy? What treatments are appropriate then? Well, all the medications that are appropriate for anyone who has dilated cardiomyopathy, regardless of Friedreich ataxia, should be in play and should be considered. For example, angiotensin converting enzyme inhibitors, they're called ACE inhibitors for short. Some examples of that are lisinopril, Zestril, enalapril, Vasotec. Also beta blockers, such as, again, metoprolol, atenolol, aldosterone antagonists, so those are medicines like spironolactone or aldactone, digoxin, which has been around for a very long time, and then if there's any evidence of extra fluid on board, diuretics or water pills could be used. Also, if someone's developed dilated cardiomyopathy, meaning the heart is big and not squeezing as well, there should be consideration for other therapies if they're appropriate. For example, cardiac resynchronization therapy, if there is evidence that the ventricles are not synchronous in how they squeeze, an internal cardioverter defibrillator, if the heart function is very poor and someone is thought to be at higher risk for abnormal rhythms, and then also advanced heart failure therapies, so things like ventricular assist devices or even heart transplant can be considered in appropriate patients for whom if those therapies are thought to be helpful in prolonging survival and also prolonging a good quality of life. So this brings up that question, if I have Friedreich ataxia, if I have advanced heart failure therapy, so very far along heart failure, where my heart function is not good enough to provide adequate blood flow to my body, am I a candidate to have those therapies? Well, the short answer is it really depends on the individual and how well they are at baseline and how much helping the heart is going to help the rest of them. There have been reports of ventricular assist devices as well as successful heart transplants in folks who have Friedreich ataxia. So ventricular assist devices can support the failing heart in more and more patients. This may be used as a bridge to get to a transplant or in somebody long-term. They call this destination therapy. These devices have become smaller and more compact so that the thought of living permanently on a machine that helps support the function of the heart has become more palatable for many people, although still not an automatic decision to be made. And there are pediatric devices, although not all of these can be put in and then have someone sent home on them. Again, successful heart transplantation has been reported in some folks with Friedreich ataxia, and really being a candidate for this therapy depends on what someone's life expectancy is thought to be if their heart was functioning well, what their quality of life is, and the hope that the successful heart transplant would help support good quality of life. And then also for many centers considering candidacy for transplant, a person's mobility and ability to engage in aggressive physical rehabilitation is very important. And this is just some of the reports in the literature about use of VADs and use of transplant in FA. So what should your doctors know about your heart? Again, just to review, your baseline EKG tracing, because it may be abnormal, is important to have. And baseline troponin level may be important, especially if you start having symptoms that are thought to be related to the heart. Your baseline ejection fraction may be important. So this is a measure of how well the heart squeezes. And we know from the very few large series of heart studies in folks with Friedreich ataxia that lower systolic function, so a lower ejection fraction, portends a higher risk of having problems with the heart in the near future. Also knowing if there's any outflow tract obstruction, again, this is relatively uncommon in Friedreich ataxia, but if it exists, should be known. Whether there's any history of abnormal heart rhythms should be reported. And then everyone taking care of someone with Friedreich ataxia should know that there's potential for what we call diastolic dysfunction. So the potential that the heart may not relax as well because it is thicker and potentially more stiff than a normal heart. For someone who has diastolic dysfunction, rapid shifts in the amount of fluid in the body are not tolerated as well as with somebody who has normal diastolic function. So things like long anesthesia courses, low blood pressure, periods of what we call hypovolemia or not having enough fluid on board should be avoided if possible. And if someone needs extra fluid to be given, the care team should be paying attention to how much fluid is going in and how a person is responding to those fluid shifts, because they may end up needing to have that fluid be taken off again in the future. Now, one relatively common problem in Friedreich ataxia is scoliosis. Not everyone who has Friedreich ataxia will have scoliosis, and certainly not everyone who has FA will need spinal fusion or surgery for their scoliosis. But for those who go on to need spinal fusion, we have an increased recognition that scoliosis surgery in people with Friedreich ataxia is probably a higher risk procedure than for others who don't have Friedreich ataxia. We think this is likely due to the potential for blood loss and fluid shifts that are not as well tolerated for folks who have FA, because they need preload to their heart ventricles, their lower chamber of their heart, and their heart may be stiffer than a normal heart. Also, low blood pressures, low blood sugars, and stress may contribute to metabolic decompensation. And the risks of the procedure itself include both fluid overload or congestive heart failure, as well as cardiac arrhythmias or abnormal heart rhythms. So many centers, including ours, have tried to put pathways together to help anticipate these problems ahead of time and prevent heart complications in those who go through spinal fusion surgery. One of the most important messages I think I have for you folks tonight is to establish your own baseline and be your best advocate. This is for you if you have Friedreich ataxia or if you're a caregiver for a loved one with FA. So don't be afraid to ask your cardiologist for copies of your baseline studies so that, we know what your EKG looks like when you don't have chest pain and you're feeling well. We know what your troponin level is when you look well and are feeling well. That way, if you show up in an emergency room with chest pain, you will be able to share with the providers there whether you have an elevated troponin and an abnormal EKG at your baseline. It's probably a good idea to start a medical binder and keep track of all your test results, or make sure you have access to, many people have applications, medical charts that are available online, making sure you have access to that and you have an up-to-date password and can access all of these things about yourself or about your loved one. And don't be afraid to reach out for input from other specialists and speak up when you have a concern. It's uncommon to meet a care team who know a lot about Friedreich ataxia without having a chance to read about it ahead of time, because it is a rare disorder. That doesn't mean that your care providers are not going to take good care of you, but helping to equip them and equip yourselves with some baseline knowledge is really, really important. So this is where I'm going to segue into, how can I learn more about Friedreich ataxia, and how can my care providers learn more about Friedreich ataxia? Well, there are clinical management guidelines for Friedreich ataxia. These were first developed in 2014 by a multidisciplinary group and then just updated last year. And these are, yes, published in the medical literature, but also available online for free to everyone, to medical providers, to caregivers, and to people who live with Friedreich ataxia. And so if I tell you nothing else, know that this website here, https://, and then frdaguidelines.org, again, available to everyone, and takes you to this website that has clinical management guidelines for Friedreich ataxia. And the following slides I have are just a sampling of some of the recommendations that come from this. Each of the sections in these clinical management guidelines contains some overview of certain areas about the care of someone with FA. Some of the language in there will be very detailed with a lot of references in the medical literature that you may find interesting or you may gloss over. It is nice to have that for a reference, but then there are also some summary recommendations. There are best practice statements. So the recommendations are generally put forward by looking through all the available medical literature on certain questions for management and for guidance and surveillance. And then the best practice guidelines may or may not have a lot of data behind them, but still a group of experts in FA have put these together because they think these are recommendations or guidance for folks that promote best practice. And then there are also lay summaries, so summaries of all this data and these recommendations for someone who does not have a medical background to be able to reference and read about and hopefully understand it at almost any level. So, for example, the clinical management guidelines do cover vision because individuals with Friedreich ataxia who have vision worse than 20/200 in each eye, it's recommended that they should be evaluated by a low vision specialist. Again, there's background in the document about this, but folks with FA are at higher risk than the general population for visual changes and vision loss. That first recommendation is actually a best practice statement because there are no specific treatments available for vision loss specifically related to Friedreich ataxia, but a low vision specialist, so an ophthalmologist, may be able to advise on aids to manage vision loss when it does occur. Visual problems that are not related to Friedreich ataxia, so for example, glaucoma, cataracts, or diabetes-related visual problems, should be managed according to usual care for those conditions and not managed differently just because someone has Friedreich ataxia. Another example from the clinical management guidelines, again, this is not my area of expertise, but certainly something I like to be able to reference when folks have questions or when I have questions. So it does speak to diabetes in the endocrine section. Because folks with Friedreich ataxia are at an increased risk of insulin resistance and diabetes, both children and adults with FA are recommended to be screened for diabetes at least once a year. And they can be screened with this blood test called a hemoglobin A1C, with a fasting glucose level from the blood, and then also with someone just reviewing, do you have any symptoms of diabetes? Have you been peeing a lot more than usual? Have you had unexplained weight loss? Are you particularly thirsty all of a sudden? So this is a recommendation put forth by this group of experts specifically related to screening for diabetes. Another recommendation is that insulin alone, rather than insulin and other glucose-lowering medicines, is suggested as the primary treatment for most children with Friedreich's because it's thought that other glucose-lowering therapy is not generally going to be adequate for those who are young and have Friedreich ataxia and get diagnosed with diabetes. Of course, this must be individualized, and that's one of the other best practice statements related to diabetes, is that management of diabetes in FA should involve the diabetes specialist and take an individualized approach, especially now that there are a growing number of diabetes therapies available on the market that may or may not be specifically helpful in an individual with Friedreich ataxia. There's a section on mental health in the clinical management guidelines, and within the lay summary, they mention that there are various strategies that may help a person with Friedreich ataxia experiencing either depression or anxiety. Those can include medication, counseling, and lifestyle changes. Another facet of the clinical management guidelines that I think a lot of people may find especially useful in this recent iteration is emergency room management. So, for example, in the emergency room section, which has its own bookmark on the webpage, if someone comes in with Friedreich ataxia and symptoms of a urinary tract infection, the authors recommended that the assessment should be standard. Do everything that you'd normally do for someone who doesn't have Friedreich ataxia, but also to recognize they may need to have their catheterization technique checked if they are performing self-catheterization at home. And then second, that an ultrasound scan may be additionally helpful for someone with FA in order to check for urinary retention. Also in the emergency room management section is a recommendation that all Friedreich patients be screened for diabetes and hyperglycemia, so high blood glucose levels if they come through the ER, because hyperglycemia may be a cause of nonspecific symptoms, and it's important to catch that, as a potential reason that someone's come in. For those who are recognized to be in something called diabetic ketoacidosis, or DKA in the ER, it's also recommended that the providers recognize that they may need a higher dose of insulin therapy because there is insulin deficiency and insulin resistance in folks who have Friedreich ataxia. Also, in a lot of detail in the emergency room section is a discussion about chest pain, which we've already touched on a little bit. And I think this is a particularly nice lay summary that can be helpful both to people who have FA and also the folks who may be meeting, caring for and meeting a person with FA for the first time in an emergency room. So in this lay summary, we lay out that coronary artery disease is not more common in Friedreich's than in people without Friedreich's. People with Friedreich's do commonly have baseline abnormal EKG and abnormal blood tests such as troponin. Those abnormalities can be seen during a heart attack in a normal person, but those can also be seen in a person with Friedreich ataxia, even if they don't have coronary artery disease. So when a person with Friedreich's presents to the ER with chest pain, an abnormal EKG or an abnormal blood test does not automatically mean that they've had a heart attack. So those are, I think, important points to be able to raise with a person. So if there aren't other risk factors for coronary artery disease, I think this is helpful information to help prevent a person with FA from going down a rabbit hole of evaluation for coronary artery disease when it's unlikely that they would have that. Also from this lay summary, it's noted that some people with FA can present with chest pain due to an episode of a fast, irregular heart rhythm. And so it's important to evaluate their heart rhythm. And then other non-heart related causes of chest pain should be considered. For example, if someone is particularly sedentary or immobile, there may be an increase of blood clots to go to the lungs, and that can cause chest pain as well. Clinical management guidelines do have a specific section on heart care and heart surveillance. So in the guidelines, there's a best practice statement that recommends an EKG and an echocardiogram at least once a year after and also at the time of diagnosis of Friedreich ataxia. Also recommended are either a 24-hour Holter monitor or a loop monitor if someone presents with palpitations or other symptoms suggesting an abnormal heart rhythm. Finally, an evaluation by a cardiologist should take place if an individual with FA has cardiac symptoms or abnormal results on cardiac testing. With respect to heart rhythm management, this expert group of cardiologists and cardiac-related providers said that anticoagulation, so thinning the blood with medicines, is conditionally recommended over not doing that in folks with Friedreich's ataxia who have either permanent, persistent, or paroxysmal, meaning on and off, atrial fibrillation. So that's a heart rhythm abnormality for which anticoagulation would be recommended. Also, this group recommended that attempts to maintain a normal heart rhythm should be made rather than just trying to control the rate in individuals with Friedreich ataxia who have abnormal heart rhythms from the top chamber. They also said that one should consider ablation, so that's an invasive procedure to try to stop an abnormal heart rhythm if someone remains really symptomatic from a persistent atrial arrhythmia or an arrhythmia that comes on and off and can't be controlled with medicines alone. And finally, with respect to heart failure management, the guidelines state that there are no suggested heart failure medicines or devices for individuals who have Friedreich ataxia with still a preserved or normal left ventricular ejection fraction. That may change in the coming years. So for folks who don't have Friedreich ataxia but have heart failure symptoms and preserved ejection fraction, there are studies now suggesting benefit from some newer medicines, and we will hopefully see over time whether those may be helpful in folks with Friedreich ataxia as well. Second, individuals with Friedreich ataxia who have a reduced left ventricular ejection fraction, so poor heart function, are conditionally recommended to be treated with medicines according to the current American Heart Association and American College of Cardiology heart failure guidelines. Finally, Advanced heart failure therapies should be considered based on individual circumstances. So a diagnosis of Friedreich ataxia alone should not preclude consideration for advanced heart failure therapies. There is evidence that we talked about before from case reports that indicates that a positive outcome in some individuals with Friedreich ataxia can be seen with advanced heart failure therapy such as VAD or transplant. So really this should be individualized and not denied or universally applied just because of a diagnosis of FA. So in conclusion, heart involvement in Friedreich ataxia is common. It's unfortunately a leading contributor to early demise in this condition. So regular screening for abnormal heart rhythms, abnormal heart thickness, and abnormal heart function is important. And finally, clinical care guidelines are accessible online to help guide people with Friedreich ataxia, to guide their caregivers, and also to help guide medical professionals in staying up to date on screening and also up to date on medical care that's appropriate for folks with FA. That's the end of my slides, but I think I still have time to be able to show the group here just a little sampling of the clinical management guidelines. Again, these are available online to the general public. So again, this website is simple, https:// and then frdaguidelines.org. And you'll see there's some explanations as to how these guidelines came to be. The table of contents gives you an overview of all of the types of topics that are covered in here. And then, let's see, for example, if you wanted to learn about orthopedic issues and Friedreich ataxia, there's an overview here. And then there are, certain questions that the expert group posed to themselves. For example, what management strategies can be implemented for scoliosis or for foot deformities. And you can click there to read some of the more the thorough text behind that. Also, you can jump straight to the recommendations that the group gave. For example, what are the recommendations about surgery for foot deformities? And if this language looks foreign to you and it's really hard to understand, you can also jump to the lay summary here to better understand what the recommendations are, what it means for you as a person living with Friedreich ataxia or caring for someone who lives with Friedreich ataxia, and again, to clarify who these recommendations are made for. And this is available online, by topic, or you can, print whole sections of this text. So I thought that was a nice resource to point out to the group here, and just for folks to know it's available. I'm going to stop there, and I guess Sarah and Kayla, if folks have questions, I'm happy to take them.
Sure. First of all, thank you so much for all that wonderful information and for showing that website. That's a great resource, and it's great that it's broken down where people who aren't doctors can understand it. I could go on there and read that. So thank you for sharing that. We do have a few questions that came in beforehand when people registered, so I will get through those. If anybody else has questions, feel free to type those in the chat and we'll get to as many as we can. Dr. Lin, you did answer some of these during your presentation, but we'll go ahead and get that information repeated again. So one of the questions that came in was, what symptoms should I be watching for and how often should I see a cardiologist?
So again, in terms of how often you should see a cardiologist, I would say at the time of diagnosis, and then in general on an annual basis, so once a year. There may be some folks who've been screened for so long that it could be appropriate to space that out further. But we don't really know for sure how to identify the folks who are at highest risk of progressing. So our current recommendations are on an annual basis. In terms of symptoms to watch for, we talked a little bit about chest pain. We talked a little bit about, exertional dyspnea, so having trouble breathing when you're more active. And then the other thing I think to watch out for is really to pay attention to, abnormal heart rhythms, and the way people may experience that is like skipped heartbeats or racing heartbeats, especially if you're not exerting yourself, but your heart feels like it's going faster than it ought to. Those would prompt me to, for example, if I was your cardiologist, I'd try to catch what the heart rhythm is when that happens. Some people are just very sensitive to their heart rate, and it may be normal and fine. Other people may be experiencing an abnormal heart rhythm, so we try to catch that and take a look at what that rhythm is and treat it if necessary.
Okay, we actually had one question that did just come in from the chat, so we'll go ahead and get to that one. Somebody has asked, as a general rule of thumb in regards to FA in the heart, what types of sedation or anesthesia, like local general, are safe or not safe for someone with FA?
Got it. So what I know as a cardiologist is that there's not actually a lot of data on anesthesia specifically for folks with FA. There have been questions that were brought up historically about, whether it's okay to use propofol, for example, and it's thought to probably be all right. Every medication has some degree of risk of certain side effects, but it doesn't appear that there are any FA-specific preclusions to certain types of anesthetics. So, for example, in other neuromuscular conditions, there's a risk of malignant hyperthermia, so there are certain agents like succinylcholine that should be avoided. But I don't know that that's been shown or demonstrated in FA. There is a section on anesthetic considerations in those clinical management guidelines, and so if you or your loved one has a surgery coming up, it is perhaps a section of the clinical management guidelines to look at yourself or point your care providers to, just to take a look and know what's out there and what's not known.
Perfect. And for everybody in the webinar, Sarah did put the link directly to that guidelines website in the chat, so you should be able to click on that and it should just open.
I think that's section 5.4, by the way, the anesthetic section of the guidelines.
Perfect. 5.4. Thank you. Let's see. Somebody asked, what cardiac measurements are useful to educate on for monitoring patient safety?
So, so from a practical standpoint, I think it's good to know what your ejection fraction is. So that's a measure of how well the heart squeezes. Now, know that there's going to be some degree of variability just by measurement differences. So the exact number is not so important so much as the range and the reader's assessment of whether that's normal, more than normal. Sometimes people have super squeezing hearts, or less than normal, and if so, like to what degree. So ejection fraction's one parameter to look at. There are other parameters that we're interested in, but more on a research basis, because we're not quite sure how much they predict long-term outcome or how much they reflect the severity of illness or disease. So there are things that we're investigating, like strain rate by echo, or degree of fibrosis by cardiac MRI, which probably, I suspect may have something to do with how well someone's heart is doing, but we haven't shown that or proven that. And so really ejection fraction, whether there's outflow tract obstruction, again, that's unusual, and then whether there's any known abnormal heart rhythms. Those are probably the basics of what someone should know about their heart. Again, also the troponin level at baseline.
All right, thank you. Let's see the next question. Somebody asked, are there any clinical trials focused on improving heart health?
I love that question. So right now I'm involved in a relatively large effort to better understand what we call the natural history of the heart disease in Friedreich is. Most of our approvals for that, and it's across multiple centers, is really retrospective, so looking back at historical data and then comparing that with what has happened over time. But there is a prospective component to that, meaning the permission from someone to be able to look forward over time at how their heart is or isn't changing. So if you're at a center like CHOP or Indiana or Montreal, University of Florida, if you're going to any of these various sites that are participating in this cardiac natural history study, you may be asked for permission towards the future and retrospectively for us to be able to look at your heart data and track it over time just to better understand what's going on with the heart. In terms of clinical trials to understand and improve the heart in Friedreich ataxia, I don't know of a lot of them that are happening right now. I am involved in one that indirectly involves the heart or heart health. It's an intervention that includes exercise and then a pill, a supplement that may help with metabolism and energy and potentially mimic exercise. So we call this exercise prescription or XREX in Friedreich ataxia. There are some on the other end of the spectrum, some gene therapy studies that are either underway or should be underway, in the coming months and years. And I know at least one of those is specifically looking at whether a gene therapy product could improve the heart over time. I don't know the details of that study, and where they're enrolling or how many folks they're aiming to get, but from natural history to trying to cure the underlying heart problem, there are studies either being planned or underway.
Perfect. And let's see, we had another question just come in the chat. Somebody has asked, will a chest x-ray determine if the spine is affecting internal organs?
So a chest x-ray may be helpful in that. And in general, an orthopedic surgeon who doesn't necessarily have to operate, but they're the right folks to help monitor and track scoliosis over time, they'll request some special x-rays that beyond chest x-ray, they'll get certain angles of the spine. An x-ray doesn't image the internal organs super well, but you can get a very good sense of whether curvature of the spine is likely to be restricting the internal organs like the lungs or the heart.
Okay. Somebody asked when they registered, what is the best medication or what are some supplements for a 10-year-old child with FA? Looking for options to help with heart health, fatigue, and things like that.
So it's a question that we all would love to answer. I don't have any evidence-based medicines or supplements to tell you these will help your child or help you and your heart health if you have Friedreich ataxia. I mentioned one study that we're doing that's looking at a supplement. It's an NAD supplement called nicotinamide riboside. We suspect that may be helpful overall for metabolism and may have secondary benefits on the skeletal muscles and potentially the heart muscle, but we haven't proven that, right? We know it's relatively safe from other studies, but whether it has benefit on the heart, we don't know. And similarly, there are lots of supplements that have been proposed. In general, I wouldn't tell you to go break the bank over any one particular supplement. But if there's good data to suggest that something you're interested in is not harmful, it may be something to consider. But I don't have any with a large evidence basis behind it to tell you ought to have your loved one or yourself taking specifically for your heart.
Gotcha. So we did have another question come in through the chat. Somebody asked, is the rapid heartbeat tachycardia, is that normal with FDRA?
So, a normal heart impulse that's just fast relative to a normal person at the same age. I do think it's probably somewhat more common to have what we call sinus tachycardia or a slightly higher heart rate than normal. But then I do have plenty of patients with FA who have heart rates in the normal range also. What's not normal or not reassuring would be an abnormal heart rhythm that's fast, right? So normal heart rhythm but fast may happen and is probably okay, but abnormal heart rhythm that's fast is worrisome and does happen more often in FA than in other conditions. And then just to be a little bit more specific about that, there's a condition called atrial fibrillation or AFib that seems to happen more often in folks with FA than in folks who have just regular non-FA related hypertrophic cardiomyopathy. So it seems to be more common later in disease, not in children per se. It's unusual for me to see it in children, but atrial fibrillation seems to happen earlier in FA.
Okay. What is the ratio of HCM and DCM in FRDA? What kind of conduction abnormalities are diagnosed in FRDA patients?
In terms of conduction abnormalities, we don't see a lot of like heart block, for example, or primary conduction delay or conduction problem. But we do, like I just said, see atrial arrhythmias, and then ventricular arrhythmias can happen, and they have been reported, but not as commonly as for other conditions like typical sarcomere gene mutation hypertrophic cardiomyopathy. In terms of the ratio of hypertrophic to dilated cardiomyopathy, it's definitely weighted more towards the hypertrophic than the dilated. And we suspect in most cases that a dilated cardiomyopathy in FA is really just a late stage severe, and perhaps they were hypertrophied before and have progressed to dilated.
Next question is, what is the effect of Skyclarys on the heart?
So I'm actually very interested in that question also. For folks who don't know what Skyclarys is, it's the recently first FDA-approved treatment in Friedreich ataxia. My understanding is that there are not negative effects on the heart, because I don't know that this would have passed through and gotten approved if there were negative effects on the heart. But the primary outcome for the clinical trials that were looking for benefit of Skyclarys were not heart-related, and I have not seen any of the detailed heart-related outcomes from those clinical trials. So, I would love to know that there's benefit. I haven't heard that there is, or I haven't heard one way or another. But if there was clear harm, we should have heard that, and it should have given us pause before approval. I do know, incidentally, folks have reported that the BNP level may be higher in folks who take Skyclarys. The other name for Skyclarys is omaveloxolone. So, I talked a lot about troponin in my talk tonight. A baseline BNP or B-type natriuretic peptide may also be helpful because, some folks have reported that the BNP level may go up even if there's not evidence of what we call heart failure in someone with or without Friedreich ataxia that's taking omaveloxolone.
All right. Somebody has asked, aside from diuretics, are there any treatments for fluid buildup in the lower extremities?
Sure. I mean, usually fluid builds up in the lower extremities because of the dependence, right? Gravity. So really what we try to do is fight gravity. So trying to elevate the legs as much as possible. And sometimes folks find that like compression stockings can be helpful for fluid buildup in the lower extremities also.
Okay. And we have a couple minutes left. We have a few more questions. I don't know if we'll get to everything. Somebody just asked, if BNP does elevate on Skyclarys, how should a cardiologist manage that? Or is that known yet?
I don't think that it's known yet, but if, for example, if I was your cardiologist and I discovered that your BNP was elevated and you had just started or were on Skyclarys, I would love to know what it was before you started the Skyclarys. That would be ideal, right, to be able to trend it. But then I'd also just want to know, how does that correlate with how your heart is doing, how your heart is doing? So, in the worst case scenario, the BNP being up could reflect heart failure, right? It could reflect that the heart's not functioning as well, it's too stretched, and that fluid might be building up. And I would expect then to see that on your exam, on any symptoms you might have of trouble breathing, and how your echocardiogram looks. And by my understanding, again, I haven't taken care of folks directly who've been on Skyclarys and we've measured I have not measured elevated BNPs. We haven't been looking. But my understanding is that this has happened and folks were not in heart failure, that it was a laboratory abnormality. And again, we need more clarification on this. I'd like to know the answer to that also. But if I hear that there's an elevated BNP, I want to know how somebody's doing. And then how does their heart look? And go from there.
Gotcha. I think we have time for one more question. This actually came in when somebody registered for the webinar. I think it's really important, just as a reminder, and a really good question to end on. What routine procedures should be included in the annual cardiac exam?
So I think really seeing someone in person who can get a good sense of how you're doing. If you're having any symptoms, try to dig on those and understand whether they're likely to be related to your heart or not. And then at least a rhythm check with an EKG. And if there are any symptoms or any concern for symptoms of abnormal rhythms, probably a longer monitor. And then some way of looking at your heart. So that's usually going to be an echocardiogram or occasionally a cardiac MRI.
All right. So we are right at 7 o'clock here. So I think we got to most of our questions. We didn't get to all of them, but Dr. Lin, we so appreciate you being here with us tonight. We appreciate your time, your expertise, and everything you do for the neuromuscular community. Thank you so much for sharing all that wonderful information with us this evening.
I hope it was helpful. Thanks so much for giving me the time, and hope everybody has a great evening.
Thank you. I would also like to again thank our webinar supporter, Reata Pharmaceuticals. We would not be able to provide community education webinars like this if not for their generous support, and we are very thankful and appreciative. If you're new to MDA and are diagnosed with a neuromuscular disease under MDA's umbrella, or are a loved one of someone who's diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. We would love to hear your comments about this webinar. If you have a smartphone, you can open your camera and point it at the QR code on the screen, and that will pop up a web page with a short survey about the webinar. If you don't have a smartphone with you, that's okay. You'll get an email in a little bit with the link to the survey. If anyone has questions after the webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. This concludes today's webinar. Thank you very much for attending. Thank you again, Dr. Lin, for all that great information. We hope to see you all tomorrow for a discussion about clinical research and Friedreich ataxia. Thank you. Have a good night.